I'm Dr. Haresh Mehta, board-certified cardiologist from the beautiful city in Mumbai. And today we're going to talk about frequently discussed by most patients, the procedure called TAVI or TAVR. Let's start with the basics. Heart has 4 chambers, 2 on the right, 2 on the left. The 2 chambers on the right have 2 valves in between. So what does the valve do? Valve allows blood to go in one direction and prevents it from coming back. Similarly, on the left side, we also have 2 valves. And that's the same process. Right side is impure blood, left side has got clear blood. Now, when these valves are normally functioning, they are soft and pliable, so they open easily. Like a door, if it's well oiled, it opens very easily. But when they get deposited with calcium or they get old, rusty, degenerated, then it gets difficult to open these valves, and these valves start narrowing. And when these valves narrow, the blood flow has to go through a smaller hole, and this leads to symptoms. This condition, when it affects the left side valve that connects the lower chamber, left ventricle, to the major blood supplying artery in the body, which is called the aorta, then this valve is called aortic valve, and the narrowed condition of this valve is called aortic stenosis. What happens to the valves over time? Any part in a car, over time, needs servicing, gets old, needs replacement. Same thing happens in the body. The heart is constantly pumping blood to different organs through the aorta. It's supplying blood to the lungs for purification. So the valves are constantly under stress, carrying so much blood under pressure. Over time, the calcium starts depositing on these valves, and these valves start narrowing. That means their opening amplitude goes down. So normally if you see the valve opens like this, over time it opens like this, over time it opens like this, over time it starts opening less and less. So the blood flow has to go through a smaller orifice. Sometimes these valves start leaking instead of narrowing. That also happens when the tips of these valves or the support system of the valve which connects it to the chamber starts degenerating. Then the valve, instead of allowing blood to go ahead, lets the blood come behind. And this blood coming behind pools in the chamber when it's not supposed to pool and can give rise to breathlessness or swelling of the body. And sometimes these defective valves are present from birth. When they are present from birth, they're already defective and their sizes are unequal. These valves are more prone to degenerating faster at an earlier age, and they're also prone to infection. An infection of these valves happen when you're brushing your teeth, which has a lot of bacteria, or you have any dental procedure done or any surgery done without cover of antibiotics. The organisms can go and deposit on this valve and cause a condition called infective endocarditis, which also can cause leaking of these valves. So valves over time do degenerate, do get old, and may need something to be done to them. Before I spoke about how is aortic stenosis formed. So let's talk about aortic stenosis in detail now. What is aortic stenosis? Aortic stenosis is narrowing of the aortic valve that connects the left ventricle, which carries good blood, into the organs through the largest artery in the body, which is called the aorta. The valve guarding this too is the aortic valve, which over time degenerates, narrows, and causes a condition called aortic stenosis because the blood flow is now restricted and going to the body at a slower rate, and the body has to struggle to receive this blood. These patients start experiencing breathlessness on minimal exertion. They may get angina or chest pain on walking, like patients who have blocks in coronary arteries. This happens because the blood supply to the heart itself is inadequate compared to the demand of the heart. Last but not the least, they feel symptoms like pre-blackouts. When I mean pre-blackouts, they feel that they're going to fall, the vision is getting blurry in front of their eyes. And when this progresses, these patients tend to suddenly have a blackout and they collapse. And the moment they collapse, they get up again. So these are 3 classical symptoms of aortic stenosis. Is aortic stenosis age dependent? Commonly, aortic stenosis happens in the 7th, 8th decade of life when it is due to degenerative process of the valves, which happens to anybody. But some aortic stenosis can present much earlier. And these are the ones which happen in people who are born with defective aortic valve. When I mean a defective aortic valve, a normal aortic valve has 3 leaflets, but a congenitally defective aortic valve has 2 leaflets, or sometimes 4 leaflets, or 1 leaflet, or more than 4 leaflets. So these leaflets, since they are not of the same size, they tend to get worse faster. So you might have a younger patient, say in the age of 40 or 50, developing aortic stenosis. And one of the commonest cause in our country of aortic stenosis, which is commonly forgotten, but still very rampant, is rheumatic heart disease. Rheumatic heart disease is caused by rheumatic fever, which is the throat infection in childhood, which goes and affects the valve, and these valves spoil or degenerate over time. Such patients may come also in their 30s. So these are one of the 3 common causes of this disease. So is aortic stenosis age dependent? The answer is most likely yes, but in some cases no, especially if there is a rheumatic fever or you're born with congenitally defective valves. So how does one know that the patient has aortic stenosis? Once we hear these symptoms, the next step is to examine the patient. So when you examine the patient in the chest area, which is the aortic area there, we can hear a sound which is called a murmur. It's a sound of the valve which is not opening well and the blood trying to escape that valve. So it gives a special sound which is called an ejection systolic murmur, characteristic of aortic stenosis. And this murmur tends to radiate to both your neck arteries, or to call the carotid arteries. That's the aortic stenosis murmur. Once you hear this murmur, there is a suspicion of aortic stenosis in the mind of the doctor, then he's going to ask for further tests. The first test generally they do is an ECG or an electrocardiogram, which is the electric record of your heart. In this, there will be markers like enlargement of the chamber, which will suggest, yes, that there could be an aortic stenosis. The confirmatory test of aortic stenosis is a 2D echo and a color Doppler, which is like a sonography of the heart. This can clearly see all the chambers of the heart, can see all the valves of the heart, can see the valve which is defective, how much calcium is there, how much thickening is there, how much narrowing has happened, and what are the velocities across these valves which are necessary for diagnosing this problem. Subsequent to that, if necessary, your doctor may advise further tests, which can be an angiography or a cardiac catheterization, or even a CT scan, or any other test he feels necessary to diagnose and plan your treatment. Once you're diagnosed with aortic stenosis, now is the time to plan the treatment. What are the treatment options? Do you need treatment? Surgical, non-surgical, medical. Let's discuss this in detail. First and foremost, this is a structural problem which will progress over time. So you need to assess the degree of stenosis, whether it's mild aortic stenosis, where the aortic valve area is big enough to allow blood and at the present moment needs no treatment and the velocities are lower. Moderate is intermediate, and severe is when the velocity across this valve exceeds 4 and the valve area is less than 1 centimeter square. So now this is very clear. What options? When it's mild, we just keep waiting and watching with regular 2D echo. If you have blood pressure, you have cholesterol, then we give medicines to control the blood pressure and the cholesterol. Controlling blood pressure can delay progression from mild to severe. Once you reach the moderate aortic stenosis and you still don't have symptoms, these are patients where we increase the frequency of testing. That means we start testing them sooner. So the mild, we may test an echo every year or maybe every 2 years. But in a moderate aortic stenosis, we will start testing the echo every 6 months to a year, or maybe sometimes every 3 months. And once you reach the severe stage, here you reach the stage where the treatment is mandatory. There was an old saying that if you have severe with no symptoms, you could still wait. And if you have severe with symptoms like a discus angina and blackouts, then you operate immediately. The new school of thought, the new data is showing that the moment you reach severe, you should not wait for symptoms and get this treated. The treatment options here are extremely clear. Medicines don't work anymore. We continue to give medicines to maintain the blood pressure and the cholesterol, but now we have reached the stage of getting it fixed. Fixing over time in the past has been a surgical opinion and a surgical replacement of the valve. That means the valve has to be removed by the surgeon and a new valve has to be fixed in, which can be either a metallic valve or a tissue valve. Now, how did the new therapy come in? What we'll be talking about. Let's discuss a little bit more about TAVI. Surgery has been a gold standard treatment for aortic valve disease. So why was there need to look for a non-surgical option in these patients? If you see the natural history of aortic stenosis, it was noted that people who were of very high age, say more than 80, 75, 85, and having other comorbidities like bad lungs or COPD, or they had a stroke in the past, or they have kidney disease, or they have multiple comorbidities, or they are very frail, these patients were extreme high risk for surgery. And the surgeon would say, let it be, rather than operate this patient. So it was like giving them a death certificate that, sorry, we can't do more. This is what we can do. Now you have to live with this problem. And we realized that this was not a small segment of population. At least 5% of the population were denied surgery. In a way, denied right to life. That's when the scientists and doctors got together and thought of designing a valve which can be put without surgery, implanted in the same aortic position, and can be done without the risk of surgery or the risk of anesthesia. And this got better, and they finally did the first in man or first in human testing in 2002. And that valve seemed to work for a significant amount of time. And the patient did not die eventually of heart problem, he died of other globulins. And that's how TAVI came into the picture. The breakthrough technology of TAVI gave hope to people who were inoperable. And it was the biggest advance in the field of medicine, especially in the geriatric population. And it was so pleasing to see these old people walk better, walk without breathlessness, walk without chest pain. Now the question came, if TAVI was working for old people or high-risk patients who were high-risk for surgery, will it be effective in low-risk or intermediate-risk patients where surgery also is an alternative, and should we offer TAVI to such patients? So the scientific community decided to do enough research and compare surgery versus TAVI in intermediate and low-risk patients and see if it works equally. Can 2 hours suffice? It seemed to work reasonably well in these criteria also. So now we have options of surgery and TAVI even for patients who initially were sent for surgery. So we need to understand now, and the responsibility of the community has gone further, which patient should I send for surgery? Which patient should I send for TAVI? Because all patients coming to us now would want a non-surgical procedure, which is TAVI. Who wouldn't want a cut on his chest if it can be managed without it? TAVI or TAVR versus SAVR or surgery. How do I decide? Decision in these cases is always a heart team approach. Now, what's a heart team approach? I do not think that any medical decision should be made by an individual person alone. When I mean individual, I mean the doctor, the treating cardiologist, or the patient itself. So when now we have patients of different age groups coming to us, we have a complete heart team discussion. One, patient symptoms, patient's history, patient's preferences have to be kept in mind, despite he may wanting therapies which are not best for him. Then the cardiologist screens through the entire process and decides that these are the pros, these are the cons of each procedure, the risks, the benefits, what will help the patient, what is long-term good for it, what medicines will he need, can he take those medicines, and his comorbidities. Then there is the anesthetist, who aids the cardiologist in assessing the risk of surgery. because the risk of anesthesia decides the therapy you choose. Then, of course, the cardiac surgeon has to be involved, because the cardiac surgeon is the one who is going to operate. If I send for surgery, then he should be happy accepting the surgery with sufficient less risk for the patient, not to expose the patient to a high risk just because surgery should be done. Then there's a radiologist who's involved. Radiologists are the ones who do these CT scans for us and give us the anatomy of different valves that is draining the body. So it tells us the calcium, it tells us the kind of valve, whether it's bicuspid, tricuspid, whether it's extremely thickened, what is the size of the surrounding structures of the valve, because that is very important in these patients, because the surrounding structure decides that what the outcome is going to be like. Will the patient also need his blood vessels like the coronary arteries handled during surgery or during TAVI? So all this input comes from the radiologist. All of them sit together and they have a score sheet. So you create a score. The score decides the risk of A procedure versus B. And this is then presented to the patient and then told to him, based on all this analysis, we think despite you wanting TAVI, you will be better off with the surgery. And these are the reasons we say so. And these are reasons why we are denying the TAVI. And ultimately, the patient is given enough and sufficient time to decide the therapy of his choice. If he still insists on the therapy which is not good for him, we revisit it through another team and try to convince him what is best for it, and then take a decision. There are some patients or family who comes back and says, what if we do neither? We let him be with this condition. So we need to understand that the risk of mortality or dying in these patients who are left alone is higher than cancer of the prostate, which is the commonest cancer seen in elderly men. So we have to explain to them that once you develop symptoms of this disease, the only course is going to be rapid downhill. And the average lifespan, once you're diagnosed with AS, is a maximum of 3 to 5 years. I hope you like this video and I have provided you enough insight on how to choose what therapy. But bear in mind, please converse with your medical doctor and take well-informed decisions for your benefit. If you like this video, please like and subscribe, and see you next time.